And now we shift on to another aspect, which is how we have heard a lot about antimicrobial resistance, and it appears that vaccination can play a big role in preventing antimicrobial resistance. And we'll have Dr. Sonal Saxena, who's Sonal Saxena is Director, Professor, and Head of Department of Microbiology at Maulana Azad Medical College. She's MD Microbiology and, of course, also a FAMER. And she's editor of the text Anand Narayan and Panikar textbook of microbiology. She's got a number of awards, Eminent Medical and Health Education Teaching Award. She's also got Dr. R.A. Bhujwala Award for Best Microbiologist of 2020 by IMM Delhi, a WHO Fellowship on Antimicrobial Resistance, and she has oration, Dr. D.S. Agarwal oration, and she is WHO resource person to develop National Antimicrobial Stewardship Program. She's also the Secretary of Indian Association of Medical Microbiologists and now the Dean for the academic part of Indian Association of Medical Microbiology. And she will address how vaccination can impact AMR. Dr. Sonal, please.
Thank you, sir, for the kind words, and thank you to CAHO for having me here for this very important topic. I think everybody from a common man to the Prime Minister is talking about antimicrobial resistance, but I'm sure the microbiologists have been talking about it for a very, very long time. So I'm going to cover my talks into a very small slides of AMR overview because we all are aware of something like this and why vaccines matter and what are the estimated reductions and what is the burden of the impact of vaccinations on AMR burdens and what are the challenges and implementation needs. Next slide, please. So, if you look at the wrath of antimicrobial resistance, it was just a small while ago when we found that the organisms were resistant to 30% of the antimicrobials tested, or were resistant to 8 out of 10. And now the situation is that the XDR, the extremely drug resistant, which are 100% resistance to antibiotics, are also increasing in our laboratories on a day-to-day basis. And the damaging effects are already manifest globally. Approximately 7 lakh people lose their life to AMR, and another 10 million are projected to die by 2050. Next, please. And India per se carries one of the largest burdens of drug-resistant pathogens, but also because a lot of availability of antimicrobials and the prescription part and the district level antimicrobial resistance labs which are not there. So WHO predicts that it's going to be a pandemic very soon, and it's happening right now, but we are not aware because it's very insidious. And we believe that by 2050 there will be no antimicrobials left, and we will be back to the pre-antibiotic era. Next, please. So, what actually happens when you have a non-immunized population and when you have an immunized population? Now, if you have a population which is completely immunized, then we know for sure that all of them are then susceptible to infections. Here we are talking about those organisms for which vaccination is available. For example, pneumococcal vaccine. So if that happens, then you will realize that a subset of the population will get affected if there is a infection. But the reverse happens if there is a non-immunized population. If there is an immunized population and is exposed to infection, then we know that these immunized people will be safe and will also not be transmitting the infection to other individuals. So that's how the two things are very much linked together, and not only sorry, they're not only linked, but they're also impacting one another. Next slide, please. So if you look at the threat of AMR which is there, there are multiple challenges which are there in developing new measures, like developing a new antibiotic. There is a cost involved, there is a declining clinical utility. If today a company markets an antibiotic, by next year it's going to be useless. Similarly, there is a high cost involved in R&D, and the pipeline is dry. We don't see anything which is coming up in the next few years. And so what is left is actually to improve our practices for hygiene and antimicrobial use, which is going on for so many years, and so also to look at the potential of vaccine which is there, because that is going to affect not only the burden of AMR but also mitigate the transmission of these infections to the other individuals. Next slide, please. So, how do these vaccines actually act to reduce AMR? They work in multiple ways. One is that they protect the individuals and there are fewer primary and secondary infections. And then there is a lower morbidity and less transmission of drug resistant strains. The This in turn impacts that there is less antimicrobial use and there is a lower selection pressure for the selection of drug resistant mutants, thereby adding to the lives which are saved. And this herd immunity is the one which we are all looking at whenever we look at the vaccination aspects, especially in adult population. So these vaccines actually have a lot of effect in a multifactorial manner. Next slide, please. Not only slowing down the AMR, but also mitigating the infection transmission. So there are four known categories of the vaccines that may each prevent AMR. Next slide, please. So amongst these categories, the first strategy is to use them against bacterial pathogens which cause community-acquired infections. The pneumococcal conjugate vaccine or typhoid conjugate vaccine or Haemophilus influenza vaccine. The second strategy is to prevent viral infections, which are often misunderstood as an illness and which needs an antibiotic prescription and are often treated with antibiotic prescriptions. So things like influenza, measles. Now, these vaccines we've already had for a good number of years. Maybe the coverage of PCV, HIV, and typhoid is low, but the coverage of measles is pretty good. And influenza also in the last few years, it has been picked up. Next slide, please. So, if you look at the last two, these strategies actually, the strategy two works to reduce the misuse as well as avoid the potential secondary co-infections which can arise after some viral infections. If there are no primary viral, there will be no secondary bacterial infections. Next slide, please. So, if we look at the strategy 3 and 4, 3 is against bacterial pathogens which are causing healthcare associated infections. Now, this is one area where we all need to be very, very vigilant. What is happening here is Acinetose, Staph aureus. Can we have a vaccine against these? And last but another important, next slide, is to prevent infections in the animals. There, next, please. So here what happens is that there is a reduced emergence of resistance. As a result, because it has been believed for a number of years now that the future pandemics are going to be of zoonotic diseases. So if your animals are protected, indirectly humans will be protected because these disease spillover will not occur. So this will also reduce the use of antimicrobials in agriculture or in poultry or in animal farming where they are used as growth promoters. But our saddest strategy is strategy 3, and I'm going to talk that also in my coming slides. Next slide, where we are not yet aware of how it's going to work. And this was a very interesting article on it's a guideline where the WHO released a technical report where they studied the impact of vaccine in reducing AMR and antimicrobial use, and most of my material has been taken from there. What they did was they assessed 44 vaccines which were targeting 24 pathogens, and they included all the vaccines. They included vaccines which were already in use, and they also included vaccines which were in development. And they looked across different settings and coverage scenarios, and they also used wider vaccine use, which could reduce global antimicrobial usage by 22%. That means one fourth, and which corresponds to 2.5 billion of antibiotic doses per year. Next slide, please. So, if we study this, what is the impact of currently available vaccines? Currently available vaccines, like we have pneumococcal, typhoid, and now malaria vaccines, it could provide multiple, in millions, it could avoid these antibiotic dosages, and which could prevent these infections and also avoid the associated treatment. Next slide, please. So it will result in a very targeted therapy of these drugs. And what are the other vaccines which are there? For example, pneumococcal conjugate vaccines. Now, this pneumococcal conjugated vaccine is licensed and is used globally and is recommended for all geriatric population, especially. Then the 20-valent pneumococcal conjugated vaccine, the PCV21, as we know it, it is under investigation, but it's still FDA approved. Typhoid conjugated vaccines. The problem with typhoid is once it goes resistant to ceftriaxones, then the outcome of the patients will be very, very doubtful with typhoid, because the carbapenem are not very good, showing very good work with the Salmonella typhi organism. There are very few studies on the efficacy of imipenem and meropenem, and they are not working as much. So there will be absolutely no protection. And then paratyphi is another problem, that Salmonella paratyphi doesn't even it doesn't even respond to azithromycin. So that's another area that we are supposed to look at. And even the typhoid conjugated vaccines, it is WHO pre-qualified, but their efficacy on paratyphi is still very low. And then you have meningitis or meningococcal vaccine, which is already licensed for adolescents and young adults. Haemophilus B conjugated vaccine, against licensed and widely adopted. Then you have a Shigella outer membrane vesicle vaccines, which is in the phase 2 trials, and it's ongoing, completely ongoing. Another adult vaccine which will be of very use in tropical countries. Then extraintestinal pathogenic E. coli vaccines. It may look a very small organisms, but it may prevent UTI and BSI in high risk populations, reducing the number of dosages. This is again a mixed pipeline and is still awaiting approvals. Then oral corolla vaccines, we know WHO pre-qualified, used in campaigns, and it can be of a lot of use in areas where cholera is endemic. RTS and other malaria vaccines, again licensed. One of the vaccine is already licensed. It is pathogen specific. It has a very indirect AMR benefit. Then glycoconjugate vaccine group B streptococcus, again undergoing phase 2 trial. Fortunately, group B streptococcus is not much a problem for us, but worldwide it is. Next slide, please. So, vaccines which are already licensed or in phase 3, let's study how they affect your AMR burden, or how they reduce the vaccine antibiotic. So if we look at the vaccines which are already available for us, for example, the serotype specific vaccine of pneumo. If you realize the look at the green boxes, they show high impact. So on all, they will avert the deaths associated with AMR if you realize 90% of the infants and the elderly with a 5-year efficacy of 25% for LRI, lower respiratory tract, and 58% for invasive pneumococcal. These are the parameters against which it was studied, and it was found that it's going to reduce everything, the hospital averted costs, the antibiotic usage, and everything. Similarly, for TB, although it will have a moderate impact on the DALYs associated with AMR or the productivity loss, but if it is given to 70% of the population of infants, then it will, yes, avert a lot of antibiotic use as well. Again, Salmonella typhi, a moderate impact on AMR deaths. The reason being that AMR, the Salmonella typhi itself is a very virulent organism, but it's going to cut down the unnecessary antimicrobial usage, which is thought of as a fever of unknown origin and given to people. Then again, Haemophilus influenza, given at to 74% of infants with a 5-year efficacy. At 93%, again, it's going to have a low impact but under study. Then P. falciparum, this has not been assessed by, next slide please, because it's just come, so it's not been assessed so well, but the predictive models say that it's going to have a very low impact. Then rotavirus vaccines, it's going to avert antimicrobial use. We all understand that a majority of irrational prescriptions come from diarrhea illnesses. Similarly, RSV, now it's part of the CDC adult vaccination program, and vaccine against Neisseria gonorrhea, again especially to a high risk group of population, because it's another pathogen which is growing very high on terms of antimicrobial resistance. Next slide, please. So if you look at the three main vaccines, we'll realize that It reduces approximately 27,000 extra AMR related deaths and 1.5 million daily loss of days and 10 million DDDs per year. TCV, on the other hand, awards 45 million DDDs of antibiotics, and the new TB vaccine, which works better than your BCG vaccine, is going to avert 1.2 to 1.5. Next slide, please. Now, remember, all these actually are the predictive models which have been built. Now, there are certain vaccines which to develop or implement have a medium feasibility. Next slide, please. So, if you look at the medium feasibility, these are the drugs which usually cause your MDR, your MDRs, and cause infections in the nosocomial settings. Vaccine against urinary tract EPEC or a bloodstream EPEC, vaccine against bloodstream K pneumoniae, but you look at the coverage, up to 70% of these coverage, and it will also not have a very high impact, but it's going to avert the antimicrobial use. Similarly, on group A, streptococci, shigella, ETEC, and pseudomonas. These are all your nosocomial pathogens, but they're going to avert the hospital costs indirectly and also avert your antimicrobial usages which are unnecessary. Next slide, please. And confusing treatments. Then vaccine against H. pylori. Usually it is not this thing, but it is under phase 2 trials. And if it is given to 70% of individuals, it's going to avert the antimicrobial use, because right now the only treatment for H. pylori is to give the antimicrobial treatment for the along with your antacids and other things. Again, vaccine against norovirus and non-typhoidal salmonella. Non-typhoidal salmonella may not be a problem with us much, but it is a huge problem abroad and in the West, especially where there are more zoonotic pathogens of salmonella, which are not seen so much in India. And again, similarly, Campylobacter. Next slide, please. So next we come down to those which have a very low feasibility, and why we are concerned with that is that this may be my dream come true. Next slide, please. That we have vaccines against these. Now there are certain vaccines which are very difficult to develop. For example, Staph aureus. It's got such a vast gamut of virulence factors that it becomes very difficult to run that, make that vaccination. Acinetobacter baumannii is again hard to deliver. It's easy to make, but it's hard to deliver. And the E. coli, which is given to infants and elderly, is, I've already said this. Then a non-serotype specific pneumococcal vaccine. Another, it faces a lot of hurdles, but it's been said now that even if you give a non-serotype specific pneumococcal vaccine, it could additionally avert a lot of deaths. Staph aureus vaccine, yes, would have a very high AMR impact, but the candidate vaccines have failed in the clinical trials. Next slide, please. So, uh, in future, if you have something which could avert deaths, would be a vaccine against Acinetobacter baumannii, Pseudomonas aeruginosa, to avert the bloodstream infections as well as the lower respiratory tract infections. Ephesium for UTI, especially in recurrent UTI, people with urinary tract problem. Salmonella paratyphi A, because A is usually doesn't get much protection from the typhoid conjugated vaccine, and C. difficile. Again, in the West, C. difficile is a more problem than in India, and it would have a lot of impact on unnecessary prescriptions of antimicrobials. Next slide, please. So, we need to integrate these vaccines into our AMR strategies. They should be a core to this. You can't just say that because we have a vaccine today, say 50 years down the lane, we have a vaccine against Acinetobacter, doesn't mean I do away with antimicrobial stewardship or infection prevention control measures or diagnosis and surveillance. So, and for zoonotic pathogens, One Health approaches, we can't take a backseat there. It has to be integrated along with these strategies, and this should be very clear to anybody who thinks that vaccination is going to solve our problems. Next slide. And even to the policymakers. So the challenges which are there are usually that there is an underuse of existing vaccines. If I ask people who are logged in today to vote for how many of you have actually taken pneumococcal vaccine or influenza vaccine, how many of you take influenza vaccine every year, the answers would not surprise many of us. there are gaps in surveillance of use and resistant outcomes. We always look at the antimicrobial resistance data, surveillance data, but we don't look at the use data and we don't look at the outcome data. Um, last year, we did a dissertation on typhoid outcomes, and we were ourselves surprised. In spite of ceftriaxone, azithromycin sensitivity, people die. So those outcomes in terminologies of the outcome of that disease are not clearly understood, especially for Acinetobacter, E. coli, and Pseudomonas. Then the estimates and to monitor the impact has to be data. Only when you give data to policymakers, they're going to work on that data. And there are vaccine hesitancy and supply constraints, cold chain management, and all these factors can also limit uptake, and it can lead to, like we can see in the underuse of existing vaccinations in many settings. Even the newer vaccine will have more hesitancy from people. We all remember what happened in COVID when people said this is going to, this, whatever is happens now after COVID, there is a pre-COVID and there is post-COVID. So everything which happens now is actually related to the vaccine in the initial part, and only then people think about other things which are responsible. Next slide, please. So a lot of these things are going to impact how much actually benefit are we going to derive from these. But still, there should be a policy and investment priority to invest in vaccine R&D for AMR relevant pathogens, especially the ones which I said is the dreamline to have vaccinations against nosocomial pathogens, and expand the access of existing high impact vaccines, strengthen the delivery platforms, the cold chain, the workforce supply. We could achieve such a good result with pulse polios and other IEC materials that we generated, and the kind of drive that we had for polio. I think we should have it for all the vaccines. And the AMR endpoint should be incorporated into vaccine impact evaluation, that if this population is vaccinated against Salmonella typhi, then what is the impact on AMR from these typhoid patients, or what is the actual reduction in the disease and also AMR? And another thing which we all forget, and after listening to all the messages from all the other speakers, I realize we often miss out a very huge population, and that is a healthcare worker vaccination. When we talk of adult vaccination, we should always talk about the healthcare workers vaccination, because that is something which is responsible for not only their own health, but also giving a transmission to the patients. So, just to conclude, vaccines reduce infections and indirectly reduce antimicrobial use, and therefore slow down the path of antimicrobial resistance. And wider vaccine usage of existing vaccines could also avoid a lot of antibiotic usage annually, and also avert almost a lack of deaths annually. Further reductions are expected when you have new vaccines, especially for TB and other vaccines, which could reduce the ATT dosages. And yes, the dreamline against the hospital pathogens, which can reduce this burden. Next slide, please. So the distribution and equity concentrations is that higher vaccine coverage should have a greater impact, and this equitable access is essential to maximize global benefit. Next slide, please. So these are the few references that I used for this. There is a excellent article which has come from, which I found on this, not in addition to the technical report, was from the evidence from the middle and the income countries, the Ramanan Lakshmi Narayan group, and another one which I found from our own country, which is there in infectious drug and resistance. So with that, next slide, please. And thank you so much. And just I will leave you with this image saying that as our life expectancy increases and we have tried to conquer a lot of things and antibiotics, if we have to keep this road up, then we have to keep our antibiotic resistance down. Otherwise, this road will not go up. So thank you so much again for having me here.
Thank you very much, Dr. Sonal.